Hi guys, let's do our CVPP lecture for today. It's Thursday, week 7, fall of 2021. Here we go. We've been talking about the heart pathology, or about the heart and its pathologies, and let's start out with something called infective endocarditis. And the source of this is Robbins, which is a chiropractic board book, and a medical board book for that matter. So what is it? Well, endocardium, so that's the lining of the heart and valves. So infection, it's an infection of the lining of the heart and or lining of the valves. That's exactly what it is. It's a microbial infection of the heart valves, or the mural endocardium. Mural endocardium. Get out your note cards, make a note card of that. What does it mean? Mural endocardium is the lining of the heart except for the valves. Simple as that. It's not good to get an infection of the lining of the heart because bacteria, in particular, can be very destructive. And they can burrow in, go through the endocardium, which is just an endothelium lining, right? Just like a blood vessel. It's not very thick. They can get into the myocardium and destroy heart muscle to the point that your heart can no longer pump and you die. So it's a very serious condition. So in addition to that, the bugs can really build up on the valves. Did I turn on my drawing tools? I did. So these bugs can start to multiply and multiply and multiply. And they can form a very large kind of a bug ball. And that can break loose. And in this case, we're on the right side of the heart. It can go and get stuck in the lungs and cause pulmonary embolism and cause infarct of the lungs, dead lung tissue. Okay. Let's see. Why aren't we turning the page? Here we go. Okay, so those are called vegetations. They're just bug balls that can break loose and cause an embolism. What exactly are these vegetations made of? Well, bacteria, live and some dead bacteria, and microthrombi. So that's a perfect sticking point, we've already said several times. Blood platelets can stick there, and you can get a buildup of blood clot, which is called thrombus when you're in the lumen of a blood vessel. What's the most common type of bug infective endocarditis? Well, you can have yeast and fungi, and there's some rare kind. By far the most common is bacteria. There's two flavors of endocarditis. There's an acute infective, which is very dangerous and often fatal. So that's a new infection of a previously normal heart. So someone who didn't have rheumatic fever, has had no mitral valve replacement or aortic valve replacement. A good heart suddenly gets infected. This is not good. The typical cause of this is the super virulent. Here's a note card for you. Virulent, what does that mean? Evil, destructive, deadly. Super virulent Staphylococcus aureus. Staph aureus is responsible for about 25% cases of acute infective endocarditis. And this condition destroys the heart valves really, really quickly. So you get regurgitation, and we've talked about what trouble regurgitation is. Plus, certain strains of Staph aureus are very resistant to antibiotics. So by the time you finally do figure out an antibiotic that will kill it, the damage has been done to the heart, and it's permanent damage. And as we said, this often necessitates surgical cleanup, where they have to open up the heart, or they can do it endoscopically these days. But they have to get rid of the bugs and literally clean it out, and it's often fatal. There's another type, usually with a pre-existing condition, someone who's had a ventricular septal defect, an atrial septal defect. And this one is typically caused by the less virulent organisms, or caused by less virulent organisms, such as viridins. Streptococci is a perfect example. It's not as destructive, but it can start to not so much destroy the valves, but warp the valves. It's associated with an inflammation, and the valves can start to kind of dehydrate and shrink in, and you get a regurgitation because of that. Antibiotics are much more successful at this one. It usually doesn't end up with any type of surgical procedure. What are the risk factors for infective endocarditis in general? Having rheumatic fever, which has morphed into, or not even rheumatic fever, I mean rheumatic fever, I don't think we'll get to that, but I have a YouTube video on it. It usually comes on from strep throat. Strep throat can be, that's why mothers and fathers hate to hear the words, "Oh, your son has strep throat," because it loves the antibody attack against that particular bug. For whatever reason, likes to hit the valves of the heart. It mistakes them for streptococci. And it's very strange, and it wrecks the heart valves and scars up the heart. So people who've had, that's called rheumatic heart disease. People who've had rheumatic heart disease are at risk for future infective endocarditis, because it's just easier for bugs to stick to the scarred up and damaged heart. People with mitral valve prolapse, degeneration of the valves, a bicuspid aorta. Remember, we usually have 3 valves. Some people are born with a 2-valved heart, or 2-valved semilunar valves, like the aortic valve is the troublesome one, and they're at risk for all sorts of problems. Or maybe they've had to have that bicuspid valve removed, and now they have an artificial heart valve. Both of those people are at risk for these bugs. And then the congenital heart wall defects, the ASD, VSD, PFO, which we've talked a lot about already. Where does the infection come from? I've talked about this. Dental procedures, surgical procedures, contaminated needles. IV drug users can get endocarditis quite commonly. Or sometimes just an excoriation, just a simple cut for whatever reason. Sometimes the cut is perfect and gets into a major blood vessel or lymph vessel, and the bacteria gets into the blood and sticks into the heart. And then probably another common one is just an infection somewhere else in your body. Maybe you have cellulitis. You got a spider bite and it got infected, and now you have cellulitis, and some of that got into the blood and stuck in the heart. Pneumonia, peptic ulcer disease, which can put a hole not on the outside of your body, but on the inside of your intestine or the inside of your stomach. That can do it. How do these patients clinically present? How would you be able to pick one of these out? Well, sometimes it's hard because there's a lot of other conditions that can kind of do this in your office anyway. Robbins uses the word stormy onset, so it's a very violent, not much of a slow, gradual ramp up in symptoms. Like with appendicitis, the symptoms come on fairly slowly. This just hits you like a storm coming in off the sea. Fever, chills, weakness, a lassitude. Another note card vocabulary word, lassitude. That's like malaise, flu-like symptoms, or lethargy. You just don't feel good. Lassitude. It's a Robbins word. Of all of those, you may not have all of those signs, but fever is by far the most common symptom. 90% of these patients, if it gets into the left heart anyway, 90% of these patients will have a valve-related murmur, or just some type of murmur. It's usually a regurgitant, but it doesn't have to be. It just could be turbulent blood flow from the bug ball embolus, or bug ball that has built up, the vegetation that has built up and is disrupting normal laminar blood flow, so you get a really crazy, loud-sounding blood flow. And then, of course, you do blood work and culture, and you can find the bug that's causing this. What are the complications? An interesting complication that does occur, not super commonly, but it definitely occurs, is when the body starts attacking the Staph aureus, it also, for whatever reason, those antibodies mistake part of the glomerulus as a target, and they think the glomerulus is a Staph aureus, as strange as it sounds. So the body's immune system gets confused, and it's like an autoimmune attack against your kidney, and you can get a wicked glomerulonephritis, and you could lose a kidney from that and get all kinds of problems because of that as well. The bugs could start releasing gradually into the bloodstream, and you could end up with a septicemia. We've said this already. The little bug ball vegetation could break loose, and that results in an embolism, just like a blood clot breaking loose. And that's called a septic embolism, and it can get stuck anywhere if it happens on the left side of the heart. Right? You can go in the coronary artery and cause a myocardial infarction. It can go up into the brain and cause a stroke. It can go in the celiac trunk and get stuck in the common hepatic artery and cause an infarct of the liver, etc. Anywhere the pipes go, this septic embolism could get stuck and cause a beaver dam, and anything downstream will die because of it. All right, so that's enough of that one. Let's go talk about diseases of the covering of the heart, or the pericardium. Pericardium, of course, is the sac that covers the heart. It's a nice example of it. Note that the sac, and we've talked about this before as well, but note that the sac of the heart is welded into the great vessels that attach to the heart, like the ascending aorta. It's welded about a quarter of the way up. It's welded around the pulmonary trunk. It's airtight here. It's superior vena cava. Inferior vena cava is quite strange because it usually doesn't, it leaves out, it doesn't include the inferior vena cava, which is kind of strange. Right? And of course we have a space in here. There's a pericardial cavity that we've talked about before, but it's really important, right? We talked about aneurysms happening, right? A DeBakey 1 or DeBakey 2. What happens if you spring a leak right here? You had an aneurysm, and now we'll make it blue blood. You start gushing blood, that blood will start filling up this pericardial space or pericardial cavity, right? And you can crush the heart. We've talked about that. It's called cardiac tamponade. And we'll get more into the weeds on that one in a minute. This pericardial sac has 3 layers. The very outside is called the fibrous pericardium. It's very tough. It's unforgiving. Can't stretch it. You could stretch it, but as long as you push on it slowly, it'll stretch. But if you try to push on it quickly, like in lab, you probably pulled on it. It doesn't move very much. And then we have a doubled layer serous pericardium. There's a parietal layer that's stuck to the fibrous pericardium. I guess I can draw this. Let's go with red. So we have an outer layer. That's the fibrous pericardium. Just draw a little bit of it. Then we have the parent, the parietal layer of the serous pericardium is green here. Those two are stuck together. You can't pull them apart. And then we have the visceral layer of the serous pericardium. And that one is stuck to the heart. You can't pull it off the heart. So that leaves a space in between. Let's see what this one does. So you have a space here in between, and that's the super important pericardial cavity. Right? Remember your gross 2 anatomy? There's a blow up of that. Okay, what's a deep? Oh, very important, aka that visceral layer of the serous pericardium. That's called the epicardium. Epicardium. Deep to that is the myocardium, And deep to that is the endocardium, and there's the chamber of the heart that, I don't know, that looks like the left atrium. Okay. When does the pericardium become clinically important? We've talked about this before. Retrograde ascending aortic aneurysms like a DeBakey 2 or Stanford A or DeBakey 1. Any dissecting aneurysm that involves the ascending aorta can potentially rip backwards and bleed into the pericardial cavity. And if that bleeding is significant, that pericardial cavity can fill up with so much blood that it crushes the heart. And that's cardiac tamponade. And yep, they're back. Oh no, they're back. Yep, on final, you got to know these. Stanford A, Stanford B, DeBakey 1, DeBakey 2, DeBakey 3. We've talked about these things like crazy, and I don't think I need to go over them again, but they're back on the test. I will quickly. Stanford A has to involve the ascending aorta. That's it. Doesn't care if it involves the entire aorta. It doesn't care if it just involves the arch. It doesn't care if it involves the descending aorta, but it has to involve the ascending aorta. Remember, the ascending aorta is from the root of the aorta to that brachiocephalic trunk, that first takeoff. Aortic arch, then we have the descending aorta. Stanford B cannot involve the ascending aorta. Anything that doesn't involve the ascending aorta, but it's somewhere else, that's a Stanford B. DeBakey 2, I like to start with, only involves the descending aorta. The dissection is only in the ascending aorta. DeBakey 1, it has to involve the ascending aorta, and it must progress. So it has to be the ascending aorta plus something. Remember, Stanford A has to involve the ascending aorta, but it doesn't care if it involves another part of the aorta or not. DeBakey 1 has to at least go into the aortic arch, or it has to be down here. You have to have two separate regions. DeBakey 3 has to be the descending aorta only. All right, cardiac tamponade. We've briefly talked about this before. That's when the heart gets strangled by a quick buildup of some type of fluid. And it's not always fluid, but it's almost always. Sometimes it's scar tissue. But it's usually fluid that compresses the heart, and that's called cardiac tamponade. And there's a cartoon of the pericardium, pericardial cavity so full of fluid it's squishing the heart. And that's cardiac tamponade. Here's a 57-year-old who comes in your office, chest pain. It's getting worse. He's got trouble breathing when he goes up the stairs. That's dyspnea on exertion. His heart rate's 120, so he's either in distress or he's got a tachycardia or something's going on. He's not sweating. I'll give you a sneak preview into the future. If you're sweating and you come in with chest pain, you have to be very worried that the patient's having a heart attack. He's not sweating. And here's a normal chest film, nice looking heart, fairly small, nice looking lung fields, costophrenic angles are sharp. Great. Aortic knob, great. Here's this patient. What do you think of this? Oh my goodness, you say, look at this gigantic heart. Well, that's the pericardial cavities just overfilled with fluid. And he ended up having a Stanford A dissection that slowly leaked into the pericardial cavity. And if you slowly stretch the pericardium, it can expand pretty darn big. And there's that pericardial cavity. We already said it's between the two layers of the serous pericardium. It normally contains about 30 milliliters, aka 30 cc's, of a pericardial fluid. Or a serous fluid. It's best called pericardial fluid to match pericardial cavity. And yeah, it helps the heart beat. It makes it so the pericardial sac doesn't create a friction layer or it doesn't create friction between there, so it lets the heart slip and slide as it beats. Normally has an interpericardial pressure of -5 millimeters of mercury, and we don't care about those numbers, but what we do care, when you take a deep breath in, there is a negative pressure inside the entire thoracic cavity. And we've talked about that before. Sound like a broken record. A lot of the stuff we've talked about before here and there. There's the pericardial cavity again. Great. All right, now let's look at some diseases of the pericardium. So first we have acute pericarditis. So peri means pericardium, card means heart. So pericardium around the heart, itis is inflammation, so it's an inflammation of the pericardium. And it is the most common condition of the pericardium, is an inflammation. Okay, well that makes sense. And it's an inflammation of the pericardium. Who cares about this? It's very difficult to tell apart acute pericarditis from myocardial infarction, from even an attack of GERD. These three can be very similar. So much pain that you go to the hospital. So it's tough to tell these apart. So the differential diagnosis for someone with suspected pericarditis is GERD, gastroesophageal reflux disease, and myocardial infarction. And yep, seen in about 5% of the patients who enter the emergency room. Most of the time it is a myocardial infarction or GERD, but occasionally it can be an acute pericarditis, meaning it comes on quickly. There are two general categories. There's an infectious and a non-infectious type. Both of these conditions involve an inflammation. One is because of a bug, it's infectious. One is not because of a bug. The infectious one, the bug-related pericarditis, is basically a bug gets into the pericardial cavity. And we just talked about bugs getting inside and sticking to the inner lining of the heart, causing myocarditis. But this is the time the bug actually gets into the pericardial cavity and causes trouble. And you can certainly have myocarditis and pericarditis at the same time. If the bug gets into that pericardial cavity, an inflammation starts, and the juices, the inflammatory juices, start to spill into the pericardial cavity. Plus, the inflammation irritates the serous cells, or the mesenthelial cells that line and make up the serous pericardium. And when cells get irritated, they oftentimes overproduce their juice. And that's what happens. They overproduce serous fluid. And you start to get a buildup in the pericardial cavity. And yeah, so you start to get cardiac tamponade. Who are the bugs that usually do this? It's usually bacteria. The pyogenic bacteria. Who are the pyogenic bacteria? Staphylococcus aureus, Staphylococcus pneumoniae are the two big ones. Viruses can do it. Tuberculosis, not so much in our country, but that can get in it. Tuberculosis is a pesky bug, isn't it? We said that likes the adrenal gland as well. But idiopathic, sometimes they can't figure out what the cause is. Maybe it's a virus that they weren't able to catch. Now what about, so that's pretty straightforward. Okay, infection, inflammation, juice. Okay, the pericardial cavity fills up with fluid. The one that's a little weird is this non-infectious pericarditis. So what in the world can that be about? So it's any other cause. If it's not a bug, you have non-infectious pericarditis. The classic examples, according to Robbins, are some autoimmune diseases. So rheumatoid arthritis, SLE, systematic lupus, erythematosus, scleroderma. They're all diseases where the body attacks certain tissues, like rheumatoid arthritis. It attacks the cartilage of joints. Systemic lupus can attack multiple organ systems. Same with scleroderma. And for whatever reason, whatever is setting off the immune system and acting as an antigen, and the immune system attacks the antigens with antibodies and the rest of the gang, T cells and such. For whatever reason, it gets the lining of the pericardium. It gets that pericardial cavity, that serous, those serous cells. It gets them confused with their original target, like joint cartilage tissue. For whatever reason, it gets it confused. And so rheumatoid arthritis attacks the pericardial cavity. Systemic lupus erythematosus attacks the pericardial cavity in addition to its usual targets. Scleroderma attacks the pericardial cavity. And that attack sparks off an inflammation, and you get inflammatory juices. Same type of thing. The serous cells, the mesenthelial cells get irritated, and they over-secrete pericardial fluid, and you get your pericardial cavity starts to fill up with juices, and your heart can start to get strangled. Metastatic diseases can do the trick as well. Cancer, prostate cancer, breast cancer. Cancer cells can get into the lymph system and end up in the pericardial cavity and start to grow there, and the body sees them, and that sparks an inflammation. Uremic pericarditis is interesting. That's from end-stage kidney disease, where some kidney breakdown products get stuck. They flow throughout the body, and they get stuck in the pericardium, and the body doesn't like the looks of them, gets confused, and thinks they're an invading virus and attacks them. Autoimmune disease, this is everything I just said. You can read that. I just said that. Other causes, radiation. People with cancer. Radiation therapy can inflame the mesothelial cells of the pericardium and cause them to overproduce juice. Status post-myocardial infarction is interesting. We'll talk about that more here in a second. We talked about this already. Uremic, non-infectious pericarditis. I just said kidney breakdown products. And toxins, because the kidney's no longer filtering urea and creatine. Uric acid can start floating around and get stuck in places. But the kidney breakdown spark an attack by the immune system, and that inflames the heart. Another sign of uremic pericarditis, you can test their blood. They're going to have, their BUN is going to be increased. Blood urea nitrogen will be high. And if you have increased, a side note here, fun fact I guess, increased blood nitrogen has a name that's called azotemia. Azotemia, expect you probably already know that, but if you don't, make sure you know it. Now, what's the deal with myocardial infarction? How in the world can that spark an inflammation in the pericardial cavity and a fluid buildup in the pericardial cavity? Well, let's talk about it. There's actually two types of myocardial infarction associated non-infectious pericarditis. There's an early onset, which usually occurs in the hospital, and then there's this weird Dressler's syndrome, this delayed onset non-infectious pericarditis. So let's talk about the early one first. So it usually occurs the day, 1 or 2 days after a myocardial infarction occurs. And when a myocardial infarction occurs, the myocardium is dead. You have killed part of your heart. And of course, the heart is very close to the visceral pericardium, right? So that dead tissue needs to be cleaned up by the body's immune system. The body's immune system will come in, and an inflammation will start to clean up the dead tissue. That inflammation, if it's close enough to the serous pericardium, it can get into the pericardium, and kind of the fire can spread out of the heart into the pericardial sac. And that's it. So you get kind of an adjacent pericarditis, kind of collateral damage from the cleanup process of the myocardium. Everybody understand that? People who have full thickness mural, full thickness myocardial infarctions are at risk. People who have a tiny myocardial infarction, but it's superficial, it's very close to the serous pericardium, that can do it as well. The prevalence is about 10% of people who have myocardial infarction will end up getting this, so it definitely happens. And this slide drives home the point that the inflammation of the pericardium is not the danger in and of itself. I mean, you can always surgically take the pericardium out and live and do just fine. But the problem is, if you're in the hospital and you get pericarditis and they think, oh my God, you're having a second heart attack, they work you up and they say, oh, it's pericarditis, no big deal. If you get another attack of pain, they just think, oh, it's the pericarditis, we don't need to work you up again. They always have to work you up whenever you have an attack of pain, because if you've had one heart attack, the next 6 weeks you're at risk for another heart attack. And many people have passed away because they thought it was a pericarditis, and they did have a second heart attack, and they just thought it was the pericarditis. So it masks the pain. The pain can be so similar. And then there's this Dressler syndrome. I do like this. This is a nice board one too. You better know Dressler syndrome. This is a late pericarditis that comes on about 5 weeks after a myocardial infarction. Patient is home. Patient is back to work. Things are going good. And he gets chest pain again. And he thinks he's having another heart attack. Turns out to be pericarditis, this late type pericarditis, which is called Dressler syndrome. This is seen in about 4% of people who had a previous myocardial infarction. The etiology is not quite understood. It's currently thought to be that same story about the damaged myocardium turns on genes in the adjacent living tissue of the myocardium, and the new myocardium has a different look because these new genes are turned on, and the body doesn't like this new look and thinks it's foreign and attacks it. So that's the theory of this thing. And then, of course, the inflammation spills over into the pericardium. Maybe it's a new heart attack that just wasn't caught. That's possible, but we really don't 100% know why there's such a delay. Key findings. I do like these clinical findings are always high yield boards in my tests. So pleuritic chest pain. I don't think we talked about embolisms this time. I'm cutting slides out. Got YouTube videos on it, but one of the signs of a pulmonary embolism is this thing called pleuritic chest pain. And that same pleuritic chest pain is very common in acute pericarditis. And it's a stabbing. I've actually had this pain, not from a heart problem, but from a pulmonary embolism. And it's probably the worst pain I've ever had, worse than I've fractured ribs and arms and fingers, and I'm pretty beat up, but this is probably the worst pain I've ever had. You can't breathe. Every time you breathe in, it's literally like somebody taking a knife and stabbing you. Very, very painful. And it's not so bad breathing out. You have to sit up. Sitting up helps, but it's very painful. I went to the emergency room, and the morphine didn't even touch this pain. They had to go to fentanyl, which did knock out the pain. Very powerful. All right, but you have to rule out differential diagnosis is always pulmonary embolism with this condition. All right, what are the findings? Other findings beside pleuritic chest pain? Fever. It's a fever. It could be there triggered by the inflammation. A dyspnea. It's going to hurt to breathe. That's kind of the pleuritic chest pain. And then auscultatory precordial friction rubs. That's a very common one, especially if you start to get a little fluid in the pericardial cavity. It starts to mask the S1 and S2 heart sounds, so you have this kind of muffling of the heart sounds. That's very, very common. I won't play these for you, but you can go to either one of these links and hear what a pericardial friction rub sounds like. And you listen to it at Nerves Point. I guess we're going to talk about a little bit more. But once it builds up and matures, it covers S1 and S2, so it's through systole and diastole. It's not really considered a murmur. which is a problem usually with a valve or a hole in the heart. This one's just a sound. It's an extra heart sound. Best auscultated at Erb's point, or maybe the base of the heart, which is the second intercostal space, peristernal borders on the right and left. You can use that sit up, bend forward, and exhale position to bring it out if you need to. And yeah, it can mask systole and diastole. Kind of sounds like leather straps constantly rubbing over each other, and it muffles the normal S1 and S2 heart sound. There's Erb's point. You should definitely know where that is. Third intercostal space on the left, peristernal border, base of the heart. Second intercostal space right and left, peristernal borders. Pericarditis versus myocardial infarction. How do you tell them apart? Sometimes it's difficult. Myocardial infarction, however, those patients typically don't have the pleuritic chest pain. It doesn't kill them when they try to breathe in. Remember, pleuritic chest pain. You breathe in and someone stabs you with a knife. They don't have it. They typically say there's an elephant sitting on my chest and they're sweating like crazy. You would think you'd be able to tell them apart with EKG. That's going to be, I'm going to try to trick you on my test right there. Because EKG findings for a STEMI myocardial infarction and pericarditis can be the same. ST segment elevation, which is very strange. 90% of patients have elevated ST segment, just like a STEMI myocardial infarction. And that's ST segment elevated myocardial infarction. Right? And I took the whole ECG section out last quarter, just to cutting down slides. Stuff has to go. This isn't high board. There's not a lot of EKG on boards to my understanding, so I took it out. I have YouTube videos on it if you want to learn it. There's a basic tracing EKG or ECG, P wave, Q, R, S, T, and notice that the isoelectric line here is about the same. Now ST segment elevation, there's the P wave, there's the up limb, or the Q wave is here. There's the up limb of the R wave. Down limb of the R wave should go below, or at least come back to the isoelectric line. It doesn't. It's hanging out way up here, so that's elevated ST segment. That's the ST segment there. ST segments should start down here. So could be a heart attack or not. Could be pericarditis. Cardiac tamponade. Let's get a little bit deeper into the weeds on this. So we know what it is. It's fluid in the pericardial cavity. Here's a cartoon of it. This happens to be blood, maybe from a ruptured DeBakey II aneurysm. But it could be clear fluid. Nevertheless, it's squeezing the heart. And that's what cardiac tamponade is. The heart is getting squeezed because the pericardial cavity is filling up with some type of fluid. Occasionally can be cells and scar tissue. But that's not good. It squeezes the heart, and we'll see exactly how that works. But the bottom line is, if the heart is squeezed too much, you're going to lose the amount of blood coming out of the heart. The ventricles can't fill properly if the heart is squeezed, so you decrease stroke volume. And that's not good. That causes hypotension. Any type of pericarditis can cause at least some overproduction of serous pericardial fluid. And so you can start to get cardiac tamponade with that. If it's severe, you can get quick cardiac tamponade. Usually blood leaking into the pericardial cavity is the big culprit for this, though. But it can be a slow build-up with a pericarditis. Remember, about 30 cc's or milliliters of pericardial fluid is normal. But if you get above 50, you're on your way to developing trouble. You have cardiac tamponade, and it may not be symptomatic yet, but I mean, you get up to 200 milliliters, you're in trouble. in some cases. In some cases of pericarditis, inflammation produces great amounts of pericardial fluid rapidly. And anything, whether it's blood pouring in or a wicked inflammation that's producing tons of fluid that's draining into the pericardial cavity, your fibrous pericardium is not going to stretch. It's not going to have time to adapt to that, and it's going to crush the heart. If it happens rapidly, 200 milliliters or cc's will crush the heart and cause significant decreased stroke volume because of the cardiac tamponade. Here's some different types of cardiac tamponade. If you have a dissecting aneurysm that ruptures, as we've said several times, you officially have hemopericardium. Hemopericardium. If you have an infection and you get inflammatory fluids and bug fluid has caused irritation, and you're getting serous fluid buildup and kind of inflammatory fluids in there, that's called a pyopericardium. If you have a fistula, what did we say a fistula was? It's an abnormal communication between two pipes. So what if you have an abnormal communication between your transverse colon and your pericardial cavity? Well, that's not good, because there's air in the transverse colon, and that can seep into the pericardial cavity, and you can start to get an air pericardium or pneumopericardium. A pneumopericardium, I think it should be pneumopericardium. Same if you get a fistula between the esophagus, because you swallow air when you swallow food in the pericardial cavity. Pneumopericardium. Same with the lung. Trachea, respirator, you get a respirator tube stuck in, trach tube stuck in, and it rips through the trachea and nicks the pericardium, and a fistula develops. You can get air in your pericardial cavity. How about the causes of cardiac tamponade? Or other causes we talked about, pericarditis, but anything that causes pericarditis can potentially cause cardiac tamponade. So the same players. Metastasis, metastatic disease, we've already talked about this, I won't talk about them again. Infective pericarditis, uremic pericarditis from failure of the kidney, we had slides on that. And then the autoimmune diseases that accidentally attack the pericardium, rheumatoid arthritis, SLE, scleroderma, to name a few. Is cardiac tamponade a systolic or diastolic problem? Well, think back to your physiology. When you let's back up even further. When you flex your bicep, what happens to your bicep? When you flex your elbow, when you contract your bicep, your arm gets bigger. When systole occurs in your heart, that's not the case. It actually gets skinnier. Systole will actually squish the heart and make the point of it, the inferior point or the apex of the heart, point upward and jab into your fifth intercostal space, left midclavicular line, and cause an apical impulse. So cardiac tamponade is not a systolic problem. Systole contracts just as powerfully as always. The trouble is the heart can't expand during diastole because of all the fluid that is in the pericardial cavity. It's squished, so it can't expand, so therefore you can't fill the ventricles. Therefore, if you don't have enough blood in the ventricles, your stroke volume and ejection fraction are significantly decreased, which is going to decrease blood pressure. So it's a diastolic problem, not a systolic problem. Okay, here's the old classic Beck's triangle. Going to be on the test, most likely. Going to be on boards. Been around since 1935. And classically, Beck's triad is you're in the hospital and these are the patient's symptoms. And if they have these three symptoms, you think cardiac tamponade from something. So hypotension, they have low blood pressure. Pericardial friction rub. So auscultate with the diaphragm at Erb's point and listen for that muffling of the heart sounds. And then extended jugular veins is the classic description. So this is a little controversial, and most of the authors agree that very rarely do the patients have all three of these, especially extended jugular veins. Those usually in reality, in this day and age, they don't really occur. They occur with a more severe strangling of the heart, which we'll look at in the next lecture. When scar tissue builds up and really strangles the heart is when that usually occurs. That finding is called Kussmaul's sign, and you have to take a breath in to make the jugular veins kind of pop out. But anyway, this is the classic Beck's triad. It should be replaced with something called pulsus paradoxus, which we'll look at next lecture as well. Pulsus paradoxus does occur with cardiac tamponade, and that's basically a drop of the pulse. Well, you're palpating the pulse on somebody. Pulse, pulse, pulse. Have them breathe in. Take a breath in, and the pulse disappears while you're taking the radial pulse. That's pulsus paradoxus, and we'll explain that next time. Let's see. Other signs of tamponade: hypotension. We said that already, right? But the hypotension may cause other signs of cardiac tamponade. So if you have low blood pressure, the heart's going. If you have low blood pressure, the body's not going to get enough oxygen. So the heart is going to sense that, and the mechanisms that control the heart rate will sense that, and it'll cause your heart to speed up. That's called tachycardia, over 100 beats per minute. If your heart speeds up, your breathing rate is going to speed up, so you get tachypnea. You might, if it's severe, you might even have a cough, which is caused by pulmonary edema that has occurred. Remember, if the heart is being strangled and you can't process blood through the heart, it's like a beaver dam or traffic accident. It's going to back up into the lungs and cause pulmonary hypertension, and that's going to start to push blood fluid into the alveoli. That's called pulmonary edema, and that's going to trigger a cough, and you might even cough up some pink frothy sputum with this. And if the hypotension is bad enough, you're going to go into shock. And what kind of shock would you go into? I mean, you go into hypovolemic shock because you don't have enough blood flowing out of your heart. But there's a subcategory, a more accurate way to describe the shock, and it's called obstructive shock, or extracardiac obstructive shock is an AKA. That means that something is blocking the flow of blood through the heart. In this case, it's being squeezed by a buildup of fluid in the pericardial cavity. What else? If you do some blood work, if they have hypotension, the renin levels will be elevated as well. All right. The R2A system was trying, but it won't fix the hypotension. It's so severe. Sometimes from gradual heart failure, the R2A system can turn on and even cause hypertension. But in this case, no. Right, here is an amazing case, a patient with severe cardiac tamponade from metastatic disease, metastatic pericarditis from prostate cancer. And look at the size of this heart. It's just amazing. They stuck a needle into the pericardial cavity and drained out 2.5 liters, not milliliters, liters of fluid. So that's absolutely amazing. But that just goes to show you, if the pressure builds up slowly, the heart can get to or the pericardial cavity and the pericardium can stretch, but it has to be a slow increase. What do you do? I mean, as chiropractors, we don't do anything. We refer to the emergency room if you see if you see that triad, Beck's triad. In the hospital, they take a giant needle under ultrascopic guidance and very carefully poke a hole right into the pericardial cavity, which is huge at this point. It's very easy to get in there. It's so stretched out. And they just suck out the fluid. And then the patient feels all those symptoms, the pleuritic chest pain, and all those symptoms go away. Although it could come back if it's like cancer, it's going to be a repeat procedure. Okay, hope you enjoyed the video. See you guys next week.